This article, titled Skeletal Muscle Biopsy, is authored by Stephanie J. Valberg and Amy Porter and delves into the intricacies of muscle biopsy techniques in horses. The authors emphasize the paramount importance of selecting the appropriate muscle for biopsy to ensure an accurate diagnosis. They highlight that although validated genetic tests are available for certain equine muscle disorders, muscle biopsy remains crucial when genetic testing yields negative results or when signalment and clinical signs suggest other myopathies. The authors then provide a detailed guide to selecting the most suitable muscle for biopsy based on the horse's history and clinical presentation. For instance, in cases of exertional myopathies, where muscle exertion triggers symptoms, the gluteal or semimembranosus muscles are preferred because these muscles are heavily engaged during exercise and more likely to display pathological changes. Conversely, in cases of non-exertional rhabdomyolysis, a condition marked by muscle breakdown without strenuous activity, the gluteal or semimembranosus muscles are chosen due to the relative ease of obtaining biopsies from these sites. The article proceeds to discuss the two primary biopsy techniques, open muscle biopsy and percutaneous needle biopsy. Open muscle biopsy, typically performed on muscles such as the semimembranosus, semitendinosus, or Sacrocaudalis dorsalis medialis, involves sedation and a surgical incision to expose the muscle. Figure 2 illustrates the biopsy site for the semimembranosus muscle, situated midway between the tuber ischii, a bony prominence in the pelvis, and the origin of the Achilles tendon. Figure 3 showcases an ideal semimembranosus muscle sample, measuring approximately 2 to 3 cm in length and 1 to 1.5 cm in depth and width. In contrast, percutaneous needle biopsy employs a modified Bergstrom needle to extract muscle tissue through a small skin puncture. This technique is particularly suited for the gluteal muscle, although it can also be used on other muscles. Figure 5 provides a step-by-step visual guide to the percutaneous needle biopsy procedure for the gluteal muscle, outlining the precise location and technique. The authors then delve into the critical aspect of sample preparation for shipping, emphasizing the need for careful handling to preserve tissue integrity and prevent artifacts that could hinder diagnosis. Fresh samples, intended for research laboratories, should be meticulously wrapped in saline-moistened gauze, enclosed in a sealed container, and shipped overnight on ice packs, ensuring no direct contact between the sample and the ice pack. This rapid processing is crucial because substrates and enzymes within the muscle tissue begin to degrade as soon as the sample is taken, and this degradation continues until the sample is frozen. Formalin-fixed samples, on the other hand, are treated differently. The muscle sample is allowed to contract for 5 minutes after biopsy to avoid contraction artifacts in the fixed tissue. Open biopsy samples are trimmed to 1 cm thick cross-sections to facilitate formalin penetration. Ideally, percutaneous needle biopsy samples are placed in tissue cassettes before formalin fixation to maintain their structural integrity. The authors stress that the volume of formalin fixative should be 10 to 20 times the volume of tissue, and that fresh formalin, purchased within the last 6 months, is essential for effective immunohistochemical staining. The article then shifts to laboratory preparation and analysis, detailing 3 primary methods for fixing muscle tissue: freezing, formalin fixing, and fixing for electron microscopy. For research purposes, fresh samples are often divided into portions for biochemical analysis, genetic investigations, and histologic analysis. Biochemical analysis samples are immediately immersed in liquid nitrogen and stored at -80 degrees Celsius, while samples for genetic studies can be either frozen in liquid nitrogen or preserved in a solution called RNAlator, which can be kept at room temperature for up to a week before RNA extraction. Histologic analysis samples require careful freezing to avoid ice crystal artifacts that can distort the tissue structure. Figure 6 depicts the process of freezing a muscle sample mounted on cork with OCT media, where it is plunged into isopentane chilled in liquid nitrogen until the isopentane reaches a temperature of -155 degrees Celsius. The article elaborates on the staining procedures used for frozen sections, highlighting a battery of stains routinely employed to evaluate various aspects of muscle tissue. Figure 7 visually presents examples of these stains and their applications. hematoxylin and eosin, staining is used to assess basic tissue organization, cellular structure, and inflammatory infiltrates. Modified Gomery trichrome staining helps identify mitochondrial abnormalities, inclusion bodies, and the integrity of the myelin sheath surrounding nerve branches. Periodic acid Schiff (PAS) reaction stains glycogen and other polysaccharides, while amylase PAS distinguishes abnormal polysaccharides. Oil-red-O staining reveals the amount and distribution of lipid, while nicotinamide adenine dinucleotide tetrazolium reductase or succinate dehydrogenase activity staining assesses the health and function of mitochondria and the endoplasmic reticulum. Finally, myosin adenosine triphosphatase staining at various pH levels differentiates contractile fiber types, namely type 1, 2A, and 2X fibers, which have different properties and roles in muscle function. The article acknowledges both the advantages and disadvantages of using fresh muscle samples for analysis. On the positive side, fresh samples allow for biochemical and genetic analysis and can be used for a wide range of histochemical, immunofluorescent, and immunohistochemical stains, including those employing monoclonal antibodies. However, there are drawbacks, such as the limited availability of neuromuscular laboratories equipped to cryopreserve samples, the high cost of maintaining such laboratories, the expense of overnight shipping of chilled samples, and the potential for artifacts to be introduced during shipping. These artifacts can make it challenging to differentiate between true pathological findings and changes induced by the shipping process, particularly in the case of acute myonecrosis, glycogen depletion, and glycogen aggregation. The article then discusses formalin-fixed specimens, noting that most traditional pathology laboratories prefer this method because formalin fixation preserves more cytologic details compared to frozen sections, and the sectioning and staining processes can be automated. Formalin-fixed specimens also offer the advantage of being less susceptible to artifacts introduced during shipping, eliminating the need for overnight shipping and ice packs, and allowing the use of percutaneous needle biopsy samples. However, there are limitations associated with formalin-fixed specimens. Many of the stains used for frozen sections cannot be performed on fixed tissue, and these specimens are not suitable for biochemical, genetic, or monoclonal antibody investigations, hindering the discovery of new diseases. The authors emphasize that, unlike traditional pathology services that rely primarily on staining, a neuromuscular diagnostic service utilizing formalin-fixed tissue must routinely employ specific tinctorial and immunohistochemical stains to identify known equine muscle disorders. The preparation of formalin-fixed specimens involves fixing the muscle tissue in formalin at room temperature for 4 days, followed by trimming to obtain cross-sectioned muscle. The samples are then processed using a vacuum-infiltrating tissue processor, which dehydrates the tissue to enable embedding in paraffin wax, which is water-insoluble. After paraffin embedding, a microtome is used to cut thin sections of the muscle biopsy, typically 4 micrometers thick. Before staining, the paraffin wax is removed from the tissue sections, and the slides are rehydrated to allow water-soluble dyes to penetrate. The article then outlines the stains commonly used by equine neuromuscular diagnostic laboratories that analyze formalin-fixed sections. These include staining for basic tissue evaluation, PAS staining to detect glycogen storage disorders, amylase PAS staining for abnormal polysaccharide identification, Desmin immunohistochemical staining to visualize regenerative fibers and Desmin aggregation, and succinate dehydrogenase A immunohistochemical staining to assess mitochondria. Figure 8 provides visual examples of these stains applied to formalin-fixed muscle sections. For investigating new diseases, ultrastructural evaluation using electron microscopy might be necessary. This technique requires preparing small cubes of muscle, approximately 5 square millimeters, leaving them in the air for 5 minutes, and then immersing them in a solution of glutaraldehyde and sodium cacodyllate buffer. The article concludes by emphasizing the significance of interpreting histopathology results within the context of the horse's signalment, history, and clinical features. An experienced examiner, recognizing patterns and similarities to known diseases, plays a crucial role in accurate interpretation. A systematic approach involves assessing muscle fiber size, shape, signs of degeneration, inflammation, regeneration, the presence of vacuoles and inclusions, and staining patterns for glycogen, lipid, desmin, and mitochondrial morphology. Acute myodegeneration manifests as pale, vacuolated fibers, while chronic myodegeneration is characterized by macrophage infiltration of degenerating fibers. Lymphocytic infiltrates suggest an inflammatory or immune-mediated disorder. Myogenic atrophy, often seen in muscle diseases, presents as anguloid atrophied fibers with concave indentations on one or more sides. In contrast, neurogenic atrophy, typically associated with nerve damage, is marked by angular atrophied fibers compressed into pointed shapes. Figure 9 illustrates the distinction between anguloid and angular atrophy in skeletal muscle. The number and type of fibers containing inclusions are also assessed, along with their staining patterns for glycogen, lipid, desmin, mitochondria, or endoplasmic reticulum. The pattern of mitochondrial staining across and within fibers provides additional insights. Ultimately, a diagnosis is reached by integrating the histopathologic findings with the horse's signalment, history, and clinical presentation. The authors underscore that the more comprehensive the information provided to the histopathologist by the attending veterinarian, the more accurate the final diagnosis will be. The article concludes with key clinical care points, reiterating the importance of selecting the appropriate muscle site for biopsy. The authors provide a concise guide. For exertional myopathies, gluteal and semimembranosus sites are preferred. For generalized atrophy, the sacrocaudalis site is most informative, and for focal atrophy, the atrophied muscle itself should be sampled. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.